So I'm here to introduce our panel here for complex and palliative care. We're going to hear from Dr. Heather Brown. She will introduce herself a little bit more in depth, but she's a palliative care specialist here at Kennedy Krieger. And we're going to talk a little bit about palliative and complex care with Laura and Joe, also our parent caregivers here. Thank you.
Okay, can you all hear me? Perfect. Good morning. Thank you all so much for being here today. My name is Heather Brown, and I'm a pediatric palliative care doctor here at Johns Hopkins and Kennedy Krieger Institute. Many people I meet are not familiar with palliative care, and I often hear people wonder what the role of palliative care is for patients with chronic complex medical conditions. So during this discussion, we will learn about palliative care. We will then hear from two families who will share their experience caring for loved ones with ASXL related disorders. So palliative care is specialized medical care for people with serious health conditions. Palliative care providers can treat patients of all ages and at any stage of illness. We treat patients with conditions that are chronic, curable, or life-limiting, and we help manage symptoms and stress of serious illnesses. Our goal is to improve quality of life for both the patient and the family. We strive to prevent or relieve suffering, and we understand that patients with serious health conditions often have complicated courses with many specialists involved in their care, which adds another layer of stress to the family. We can help with communication and care coordination to ease some of that stress and ensure that treatment decisions are in line with your goals. Providing care and support to our patients and families requires regular, open communication among the patient, family, and all of the medical providers involved in the patient's care to help families navigate their medical journeys. So how does palliative care provide support? We aim to relieve suffering by both treating physical and psychological symptoms. We help families navigate difficult, often complex decisions and treatment options. And we do this by getting to know your family and what's important to you. So ultimately, we can make decisions that align with your goals and your values. We stay in close communication with all the medical providers, caring for our patients to coordinate care in a way that best meets the patient's and family's needs. And we provide support for the entire family unit. Palliative care is a specialty that focuses on quality of life. We provide pain and symptom management to alleviate distressing discomfort. We provide emotional and spiritual support and assist with family coping. We help with family-centered, goal-directed decision-making, as well as advanced care planning to ensure that decisions are made in alignment with the family's values. Palliative care emphasizes interdisciplinary communication and care coordination. The goal is to optimize quality of life for the patient and the entire family unit. Palliative care may be beneficial at any stage of illness and can complement life-prolonging treatments. The ultimate goal of palliative care is to improve quality of life. This umbrella term captures many different aspects of care, including symptom management, psychosocial support, exploring goals of care, and advanced care planning. The goal is to live as well as possible for as long as possible in the face of serious illness. This image illustrates the symptoms and challenges associated with the various ASXL-related disorders. Some of the more challenging symptoms for families and providers to manage include neurocognitive symptoms, communication challenges, behavioral issues, and GI or feeding issues. While the medical needs of children with neurological conditions are vast, the neuropsychiatric features can become some of the most difficult for families to manage and for providers to control. These symptoms include dementia, neuroirritability, aggression, self-injury, impulsivity, sleep dysregulation, mood disorders, sensory alterations, and psychosis. A comprehensive and collaborative palliative approach can improve quality of life for patients and families. In fact, I co-founded a combined neuro-palliative care and neuropsychiatry clinic here at Kennedy Krieger to address this specific set of needs. Palliative care providers spend time getting to know both the patient and the family. We consider each family's unique situation and identify ways to make their journeys a little easier. We strive to determine a treatment option that is aligned with both the patient's and family's goals and addresses the comprehensive needs of the patient. To do this, we offer symptom management, communication, family support, guidance, resources, and connections. When your palliative care provider is getting to know your family and your values, they may ask questions such as, what are your guiding principles? What are your hopes? What are your fears? What brings you and your child joy and meaning? And remember that these values and goals may change over time, so it's important to continue to reassess. Families may have different values and goals, and these change over time as the disease manifestations evolve. Some examples of goals are to improve mobility and independence, to maximize comfort and happiness and reduce pain and suffering, to spend as much time together as a family, to stay at home and out of the hospital as much as possible, or to protect your child from invasive interventions and procedures. Your palliative care doctor will ask questions to understand your experience. They might ask, what has it been like to be on this journey with your child? How do you define quality of life for your child and for your family? How do you make decisions? What factors do you prioritize? What does a good day versus a bad day look like at home? And how often are these happening? When you face difficult times, what helps you get through them? Family, faith, the community. What do you do to take care of yourself? Many of the children I take care of have significant medical complexity. Some of them are followed by both palliative care and complex care. And while there is a lot of overlap between these two services, there are some clear distinctions between the care provided by these two areas of expertise. Complex care treats children who require multiple specialists, have conditions that affect multiple organs, or have frequent hospitalizations or home nursing care. They coordinate care among specialists. They work to develop comprehensive plans of care for each child by coordinating input from various specialists as well as the family. Some provide primary care and some are more of a consultative role. The goal is to oversee the child's care. Palliative care treats children with chronic, complex, progressive, or life-limiting conditions. Palliative care providers aim to alleviate negative, painful, uncomfortable, or debilitating symptoms. They develop care plans to maximize quality of life for the child and the family while reducing pain and suffering. They help families decide which interventions are and are not appropriate for a child based on the family's goals and values. Patients may continue to pursue curative treatments while receiving palliative care. The goal is to improve quality of life. Many children can benefit from both complex care and palliative care, and some institutions have one of the services or the other, but not both. I want to share a resource with you. This resource, Courageous Parents Network, or Neuro Journey, a part of Courageous Parents Network, is a great resource available on the Courageous Parents Network website. This is a tool that walks you through the phases of life with a severe neurological condition, illustrating the challenges you might face, anticipating the conversations you may have, and preparing you for important medical decisions. The phases include adapting to the diagnosis, building strengths and core skills, adjusting to changes and illness progression, and navigating the medical and emotional considerations as your child's condition declines. This is a resource I often share with many of my patients and families, and many find it helpful as they navigate their own neuro journeys. Now we're going to explore some myths about palliative care. Myth number 1, palliative care is for people who are at the end of their lives. In fact, palliative care should be integrated early in the disease process while disease-modifying treatments are being offered in order to maximize quality of life and ease symptoms and suffering. Palliative care may begin at the time of diagnosis, and we can collaborate with the patient's care team as they are undergoing disease-directed therapies. As the condition progresses and disease-specific treatments become more limited, the role of palliative care may evolve. Goals may shift to a more comfort-focused approach in order to optimize quality of life. Even after a patient dies, the palliative care team can continue to support the family in their bereavement. Myth number 2, palliative care is hospice. Actually, hospice is only a small portion of palliative care, which occurs at the end of life. Patients can receive palliative care throughout their journey, even starting as early as time of diagnosis. They only receive hospice care when life expectancy is less than 6 months. Palliative care is an added layer of support offered to a child and family with a diagnosis of a serious illness with uncertain outcome. It may be offered at diagnosis or at any stage of illness. It's concerned with the whole child and the whole family, including physical, emotional, and spiritual components. It may be delivered in the hospital, in outpatient clinics, or in the home by a community palliative care team. Hospice is supportive care without curative intent. This is offered when quality and not quantity of life becomes the #1 priority. It's offered when the disease is no longer responding to medical treatments or there are no further medical interventions to treat the underlying illness. It's offered when life expectancy is less than 6 months if the disease follows its natural progression. The focus of hospice is management of physical and psychosocial symptoms and suffering. Children who are enrolled in hospice who receive Medicaid are also eligible for concurrent care. Concurrent care allows children to be enrolled in hospice while still receiving ongoing or new treatments that are disease-directed. Myth number 3, palliative care is only used to treat pain with morphine. Pain is one of the many reasons for a palliative care referral. There are many options to treat pain, both medications, which include opioids like morphine, and other classes of pain medications, and also non-medications like massage, acupuncture, aromatherapy, even things like PT and OT. And there are many other symptoms a patient may be experiencing that palliative care can alleviate. These include nausea, vomiting, diarrhea, constipation, loss of appetite, trouble sleeping, fatigue, anxiety, depression, itching, irritability, restlessness, behavioral concerns, spiritual distress, and caregiver stress. Myth number 4, palliative care sounds like it would be too expensive. Palliative care is a medical specialty, just like neurology, gastroenterology, cardiology. And in the community, insurance covers palliative care visits the same way they would cover other specialty visits. If you are concerned about the price, contact your insurance company before scheduling a visit in the community. Myth number 5, when we work with palliative care, we will no longer see our other physicians. Actually, palliative care doctors work with your other providers to assist in the management of symptoms and quality of life, and they do not replace the other providers. The palliative care consult team will work with the primary team and other specialists involved to come up with a treatment plan. One of the best parts of this work is working with families. These are the people who are with our patients day in and day out. They know the patient better than any medical provider. It's an inspiration to see their dedication and devotion as they provide excellent care 24 hours a day, 7 days a week. I am so honored that I get to do this work and meet amazing caregivers every day. It is now my pleasure to introduce Laura and Joanna as they share their experiences caring for their children with ASXL-related disorders and working alongside their palliative care and complex care providers. Thank you.
So this is a picture of Juniper doing her most favorite thing in the world, which is playing in water. She is 5. She's globally developmentally delayed. She does walk. She's non-speaking. She does use an AAC device to communicate, and also some sign language as well. She does have an ASD diagnosis and receives all the therapies: ABA, PT, OT, speech, and music therapy. So the reason why we ended up at palliative care, really, the pictures say it more than anything else. Juniper's life since early infancy was characterized by pain. She would have pain episodes of high intensity screaming, where she would arch her back, curl her feet, come out in a rash, and there was no correlation between these pain episodes to her diet, her activities. Sometimes they would last hours and occur multiple times a day and were completely debilitating on her quality of life and development and extension, that of my husband and my other children. She did have extensive GI testing, including a 24-hour pH probe, which was quite a traumatic test, but all the testing came back normal, which was obviously good, but really frustrating at the same time. So actually Juniper's PM&R doctor referred us to palliative care, and it was an absolute game changer for our family. I just want to add a side note that it's already been mentioned, but even some of Juniper's medical team, like her PCP team, were unaware that palliative care could be, well, it was so much more than end-of-life care. So we were so glad for the referral. So once we got referred to palliative care, we're from Michigan, so we go to the University of Michigan at Mott Children's Hospital. One of the great things, we live 2.5 hours away from the hospital, so most of our appointments were done virtually. And the thing that impacted me the most was the first appointment was about 2.5 hours long. And the doctors really listened to everything that I had said. They listened to me cry, they listened to me just desperate. And kind of along the way, we kind of had this diagnosis of visceral hyperalgesia for Juniper, which is obviously definitely not a scientific expert, but how it's explained to me, this brain-gut connection and a hypersensitivity to pain in the internal organs. So the nerves in these areas become hypersensitive and sending signals to the brain, telling it that these normal bodily processes that shouldn't cause pain are causing pain. And so Juniper's doctor explained to me that the goal of treatment was to turn down the volume of these signals as well as their frequency. We did try various medications, clonidine, gabapentin were examples, and they had no success with Juniper. And her current medication is Lyrica or pregabalin, which is working really well. So some of the benefits of palliative care, again, it's previously been mentioned, coordination between specialties. We have one point of contact, which as many of us know here, when you have so many doctors, sometimes it's nice to have one doctor that can kind of coordinate everything. Extensive knowledge of medications, also a holistic approach. One challenge we have with Juniper is that she's oral and she refused to take medications. So we have this medication that we're trying, but we can't get her to take it. Or my husband and I are trying hours in a day to try and get her to the correct dosage. So they worked really well with us on that. Also availability. At some point when Juniper was really bad, we were contacting them every 2 days, making medication tweaks versus, waiting maybe 6 months to see GI or neurology, getting those medication tweaks done in a few days. So resulting in the least amount of extended pain. Also emotional and practical support. I felt validated. Sometimes with the negative, the testing coming back normal, I felt like I know something's wrong and we need help, but we didn't know where to get it. So we felt validated, we have hope. One of the main things that sticks in my mind that the doctor said to me was, I have a plan A. If plan A doesn't work, I have a plan B, and I have a plan C, and I have a plan D, and so on. And that was just such a relief. And the biggest benefits really can be shown by these pictures here. Juniper's life drastically changed. These pictures, she attended a nature preschool where she thrived and was engaged. She made improvements in her development across the board and fine motor skills, being able to draw, big developments with her communication, specifically with her AAC device. I hear M&M splashback all the time, which I love. She also vocalized a word, which was football, which my husband was very excited about too. So really amazing benefits. And obviously palliative care may look different in your state, in your country, but it helped our family so much. So it may be worth something, maybe something worth looking into for your family too. Thank you.
Okay, great. All right, thanks everyone. So this is my son, Alex. He's 13 years old. Also has developmental delays, completely nonverbal. He doesn't have any words, learning to use a Tobii Dynavox. Some of our biggest challenges recently have been his neurogenic bladder and chronic kidney disease, but like many of you, we see all the specialists, GI, ortho, neuro, and on and on. And so, what we found is, traditional primary care doctors, whether that's family doctors, pediatricians, they're not really trained necessarily to manage the complexity that our children have, right? And it takes a lot of time, especially in focus many different areas to try to reconcile, and they also just may not have the bandwidth. Sometimes too, when you're going, like, let's say we had an orthopedic surgery that we needed, there's a lot of other things in an inpatient stay beyond the surgery itself to manage the care, right? So Alex needs special equipment in the hospital. He's like rolling all over and pulling off the leads, and there's like certain behavioral other supports where complex care can provide that holistic approach to manage everything. The other challenge we have, and I've heard this from families too, is you go to different specialists and they provide conflicting information and no one is bringing them all together. So like we had a meeting last year, a complex care doctor organized with 8 different specialties. I was like, finally, they're all talking to each other and aligning on like, what is the best plan of action for Alex, and like, in what sequence do we need to do things, and thinking about him as a whole person. With respect to pain, we also had a lot of pain issues, and our PCP was like, go to the emergency department, right? And they're there for urgent issues. I was like, this is a chronic pain problem, right? And so having palliative care, our palliative care team has like a 24/7 phone. They have a team of people. I can call them anytime. It's really helped prevent us from going to the hospital, which is hugely beneficial. And so our son's needs over time have become more complex, and this impacted our entire family. And so I think another thing that I found to be really helpful about palliative care is it's also not just about Alex, it's about our whole family. And so, they want to know about Alex's siblings, and they referred us to, like, there's a SIB shop program. It's all around the world. where siblings can go and meet with other siblings. It's usually facilitated by a facility, and they have professionals. They can learn about their own life experiences. It's like a group therapy, but also play. And that's really helpful. They've also done things like they have a social worker on staff, and she provided resources of adaptive hiking trails in the area, right? So it's not even just about medicine, it's just any aspect of your quality of life that can make things better. So we live locally in Maine, so that's where our palliative care team is based. And at the time, like, they didn't have a complex care. So when for certain major surgeries and things, we go to Boston, and that's where we see our complex care. So it's been great. Also, the two of them have connected. So our palliative care team manages a lot of the specialists we have locally, and then our complex care team manages all of our doctors in Boston. And if we have an inpatient stay, then they hand off to palliative care, and there's continuity there. They help to also organize things to complex care for inpatient stay. So as I mentioned, like, one of the things that's been beneficial to us is there's 24/7 clinical assistants who are watching Alex throughout the night, so I can sleep, or I can take a walk, or go for a meal, or, because he's nonverbal and has like severe cognitive impairment, pain is managed differently than it would be for all of us, right? So maybe Alex needs an epidural and he needs Valium post-surgery because he's spasming and scared about what's happening, and he doesn't understand and how he responds to the pain. And so they coordinate with all the different departments to ensure that we're planning for those days and that everything comes together across all the people involved. And it's a single point of contact, right? And I can reach out to them anytime. Similarly, a lot of the specialists, it can take 3 to 6 months to reach out. I can go in the portal and contact them, and they respond immediately. So it's like you really feel like they're there on your side. They understand what you're going through and the complexity of it. And then, as I said, too, the pain issues. So one of the things that's been really helpful to us that our palliative care team created is this INRS scale. It's a numeric rating scale. And there's different tools that are out there that you can see, like, what works for your palliative care team. But we have a lot of different nurses and providers who work, caregivers, school folks, et cetera, who work with our son. And so what we did was we defined, like, from 0 of no pain to 10 possible, what are some of the things of ways Alex expresses pain, right? So when he's at a 10, he's like screaming and crying, and he starts biting and hurting himself. And, there's a certain escalation to get to that point. And at each of these areas on the scale, like, what does that look like? What can we do to comfort him? What are preventative things that we can do? Because once he's already at a 9, it's a lot harder to come down, right? So, and it's a combination, like they said. I mean, some of this are medications, but there's also a lot of comforting things like heating packs or aromatherapy, music, etc. So lots of different options in terms of interventions. And then just here are a couple of resources to share with you. I know Dr. Brown mentioned Courageous Parents Network. I think they're also on social media. There's a Pediatric Care Coalition. And then, as I mentioned, the SIB shops for all the siblings. I believe these are around the world, and you can find one that's near you. All right, thank you.
Thank you all very much. We're going to open up for some questions. So far, we've only got one, so please feel free to ask questions on the Slido app. I do want to, just one bit of housekeeping for everybody here and watching virtually. If you've asked a question and we haven't been able to answer it, some of the questions, or we haven't answered it in either the chat or live, some of the questions we're being asked, especially from the last session, are very complex questions. And they are better suited to future webinars and other long format discussions that we'll moderate through the R Foundation and post to the website, and we'll let everybody know about that. So the first question we have, I think, is for you, Joe, is did the palliative care specialist change Juniper's diet as part of management?
No, they didn't. That is something that we previously tried with GI and with a pediatrician, and it had no impact on Juniper. We tried several different diets.
Okay. Is PMR doctor best to manage care? I don't know if that's for you, Dr. Brown, in general, yeah. The question is the PMR doctor best to manage care? So,
I think there's a lot of benefits from many different specialists. That PM&R can be very helpful for things like tone and pain, movement concerns. So I think they're a great addition to the team. I think it depends which aspect of care you're referring to, but I do think PM&R doctor can be really helpful in many aspects of care.
okay, thank you. There is a question here, and Amanda, maybe this is best suited for sending back to the website. Can we put the slide back up that has the Venn diagram of the ASXL 1, 2, and 3 symptoms? It was only briefly up. I think that is on the website, right?
Yes, it is on, if you go to ourfoundation.org/ASXL-syndromes, it's on that page.
Great, thank you. Dr. Brown, there's a question about insurance covering palliative care, and what about government provided health insurance? I know it's going to differ from state to state and plan to plan, but
Most insurances, including state and federal insurance policies, will cover palliative care. I have not had, I don't think, any issues, but before you have your appointment, I would just check with your insurance, check with the institution, and make sure it is covered, but really it shouldn't be an issue.
okay. And usually with referral, or that also depends on?
That's a good question. I think it depends on the insurance policy.
Okay, thank you. Joe, what medication did you say finally helped Junifer? And were you able to administer the meds orally?
So the medication that is working that we're currently on is pregabalin or Lyrica, and she takes it orally, and she won't take any liquid medications. And we've tried every possible mix in, and it doesn't work. So what works for her, which is kind of how we work with palliative care, was a capsule, take out the powder, and sprinkle that on food, and we find that has the least taste, and she will accept that.
Okay. And how often do you both see your palliative care specialists?
I mean, I think there's ongoing appointments and outpatient, I don't know, at least like twice a year. And again, we do a lot of telehealth as well. Sometimes it's more frequent, like Alex has had some very major surgeries. And so there was a lot of planning leading up, as well as like post-op check-ins where it became more frequent.
So we do a check-in every 3 months through telehealth. But when we were right in the thick of it, and we were still figuring out the best course of action, we'd meet every 3 days.
I'm going to toss out a question. I know that every time we go into the hospital with Asher, despite the fact that we're in the same hospital network and the chart is always there, we are always repeating to every caregiver that Tylenol does not work for him. He needs to have Motrin. Is this, so how, when we're going in for an ER visit or something like that, can we avoid that continued topic at every stage of the, if we're using palliative care specialists?
I mean, like for us, the complex care does that. So they, there's a very strong connection. So there's a complex care outpatient and inpatient. And so they put together the plan, like if it's a planned thing, and then there's also certain things in the file that we can specify, as well as like child life has sort of this document that they laminate and post in Alex's room of like, about things that are like sensory for him, or just that he's not verbal, how to approach him, any kind of guidance for anyone's coming in and out of the room on the more, I guess, softer side versus like the medical side.
And I think for here at Kennedy Krieger and Johns Hopkins, we have similar, we have both complex care and palliative care, inpatient and outpatient. And usually we work together. There's a specific patient care plan that the complex care team helps us make for patients. And that's on the electronic medical record. It's on the home page. So when you open the patient's chart, it pops up with a very detailed history and explanation of what things work and what things we should try, who to call, who to contact when there's any sort of issue. And then we also have electronic sticky notes that show up in the electronic medical records that are hopefully read when the patient goes into the emergency room. And that way, the providers know, what things to pay attention to, what things to avoid. And we also encourage all of our patients who are followed by palliative care to have the emergency room page our service right when they step foot in the emergency room so that we can get involved pretty quickly and advocate for our patients when they're in the emergency room and then when they're admitted to the hospital.
The other thing I would say is this part of our comfort plan that I shared. So like Alex has regular dosing of gabapentin, but like if the pain is at a certain level on the scale, he gets Tylenol or like additional drops of medical cannabis, right? And so, and the care and that comfort plan is also shared with any person that works with Alex.
Here's a question of how does palliative care help to differentiate what might be pain and what might be frustration, behavioral issues, partly due to the kids being nonverbal? I know we all go through that.
That's a tricky one. I think it really depends on the patient. It depends on the situation. Sometimes it could be both. So a lot of it is getting a good, thorough history from the patient and family. The family is with the patient all the time, so they see, you know, what could have been a trigger for that, what happened before the pain episode, what happened after the pain episode, what helped alleviate the symptoms. Getting a really thorough history, this is why we spend so much time with our patients, really kind of getting a sense of what's happening, will help us figure out what is going on. And we can't always figure it out. A lot of times, you know, when patients are not able to communicate, when they are nonverbal, frustration can mean a lot of different things, or behavior issues can mean a lot of different things. It can mean frustration, it can mean pain. So there is a lot of trial and error, trying to figure out, you know, we try this thing and it doesn't work, or it does work. If it doesn't work, what do we try next? Having those plan A, plan B, plan C, and just troubleshooting from there.
I would say sometimes it can be challenging, right? You know, we have a lot of different nurses for Alex, and sometimes it's someone's perception. Like sometimes he has this like heavy breathing, and we're like, is this behavioral or is this something else? Sometimes it's understanding the context of something. Like maybe he was just doing a lot of walking and now he's uncomfortable. So maybe first we'll just try like changing position, or we'll use some arnica cream, or maybe some kinesio tape, like trying the like lower impact things first, I would say, before going to a point of like needing medication and looking over time of how that appears. But it's somewhat of an art and a science.
And I think, sorry, I think that's partly why the frequency of follow-ups for palliative care can change over time. If we have a lot of behavioral issues or a lot of pain issues in a short period of time, we might be seeing the patient very regularly in short follow-up intervals to make sure that we're addressing those needs and trying to figure out what's going on. And then once we have a symptom under control, it might be a few months before our next follow-up appointment if everything is going well and there's no major needs during that period of time.
Thank you. Dr. Brown, I think this is a great question of the difference between a developmental pediatrician and the palliative care specialist. There seems to be a lot of overlap there. How do we make that distinction?
There is a lot of overlap. There's distinctions in our training, and there's certain issues that, you know, I would feel much more comfortable managing, and other issues that a complex care pediatrician might be more comfortable managing. I think in general, more primary care related or comprehensive disease-directed care would probably fall more into a complex care provider. So things like managing nutrition, managing certain symptoms that might not be quality of life symptoms, if that makes sense. And then things that are more quality of life focused, like pain and making medical decisions about invasive procedures or things that would overall impact quality of life, would fall more into the category of palliative care. I will say, at least here at Kennedy Krieger and Hopkins, we are constantly communicating between palliative care and complex care. We have weekly meetings where there's a lot of really close communication because a lot of our patients do receive both services. So I think in general, both services can benefit really complex patients, and there is a lot of overlap.
So we have a few minutes. Joe, there's a lot of interest in Juniper's story. and what the meds do that you're working on, if they're if the idea is that they're stopping the organs from transmitting as much of the brain, and also just sort of a little more about Juniper. What time was she having more pain at certain times of day after feeding? Could you just dig into that a little bit?
Yeah, so really the frustrating part with Junie was that there was no correlation. We couldn't, I mean, I probably had 20 to 25 pages of data that I had kept of trying to see, oh, I guess, is it connected to stress? Is it connected to what she's eating? Is it connected to a certain time of day? And there was nothing between myself and, her medical team that we could figure out that had a correlation. So that was a challenge. That was a big challenge, really. Yeah.
Thanks. I think
And that class of medications, Lyrica or pregabalin and gabapentin or Neurontin, are medications that calm down the brain in general and calm down a lot of the things related to the brain. We know that the brain controls pretty much every aspect of the body. So things that can be uncomfortable related to neurological conditions often do benefit from things like gabapentin or pregabalin.
I think we touched on that other, oh, here's a new one. Oh, that's just great. And I think we talked about continuing to see your palliative care physician, how often, and needing a referral. And I think we talked about that. So I think we're good. Amanda, do you want to?
And I'll just say, I always tell my patients, the goal is to reduce stress and not to increase stress. So if the frequency of follow-up is adding more to your plate or making it more stressful, then we're not achieving the right goal. So I usually will put it in the hands of my patients. Unless there's a major issue happening, I'll ask them when they would like to follow up with me. It often is usually that 3-month interval is a pretty comfortable interval. But the goal, of course, is never to add more stress or more to your plate. It's to reduce that stress.
Thank you. Okay, thank you to all three of you. It's really helpful and informative for all of us.